Welcome to Conversations with Dr. Libby. It is such a joy to be here and to bring these conversations to life. I have wanted to do this for such a long time. There are three pillars to my work: biochemistry, nutrition, and emotions, or you could say mindset. So I look at absolutely everything through those three lenses, and through these conversations, we're going to apply those lenses to lots of different topics. But for this first series, it's all about iron. Sometimes these conversations will simply be me having a chat with you, and then other times I'll invite other people who are experts in their fields onto the couch to have what I hope are some really insightful conversations that bring immense benefits to your world. But either way, I hope these conversations deepen your appreciation of your extraordinary earth suit, because after all, we look after what we care about. Welcome to Conversations with Dr. Libby. Thank you so much for joining me for this very special episode. I'm very much looking forward to introducing our special guest to you today. But before we do that, I guess I want to bring to life the theme in this episode of really the untold story of iron deficiency and all of the different ways it's affecting women with their health. It's something that I have witnessed time and time again, and I can't bear the unnecessary suffering. So with the conversations that we have today, I think it's so important to shine a light on this topic that too easily today gets skimmed over, because it's as if other nutrients have become more popular. So this obviously is part of a series where we're covering all things related to iron to educate, and I hope also inspire you to address iron deficiency in yourself or your loved ones. And today I am beyond grateful to be joined by the very amazing Lara Briden. Lara is a naturopathic doctor and best-selling author, and her books include The Period Repair Manual, The Hormone Repair Manual, and Metabolism Repair for Women. She's someone I have learnt so much from, and I so very much appreciate her joining me for this conversation today. Lara, thank you for being here.
Thank you for having me, and congratulations on the iron book. It's truly, in preparation for today, I read the whole thing cover to cover. So I hope I can, keep up with you in terms of knowledge of iron. There's so much to it. One of my friends said, wait, she wrote a whole book on iron? I'm like, yes, there is that much to cover with this, as you say, a very important nutrient.
Thank you so much. There's so much detail to it, isn't there? And I think bringing these conversations to light so that people can learn and then ideally act on it in their own lives, and where they might be, other symptoms might be appearing for them that they think are something else. It could just be as simple as iron deficiency. Of course, it can be more complex, but I'm looking forward to it.
Absolutely. Almost with many symptoms, including mood symptoms, is always in the background. Or could it be iron?
Very much. And if we're not testing it, then we can't know. So,
absolutely.
So why do you think iron is such a recurring theme, such a recurring problem for so many women?
Yeah, well, I think it's a combination. It's our modern world of the modern food supply, which is a combination of, processed food, and also of avoiding animal protein products, avoiding meat is contributing to iron deficiency. I mean, of course, I've written about this. I think you might have written about this a little bit. Our even fairly recent ancestors used to eat a lot more organ meats. So I have a quiz for, you or people listening. Like, when you were growing up, how often were you fed organ meats? Because I was a kid in the 70s, born in 69, kid in the 70s. We were, liver was once a week. It was on the weekly rotation. That was still the old way of eating that was kind of coming through from previous generations. And we've been severed from that in our modern world, that sort of more traditional way of eating. Were you fed organ meats when you were?
Sheep's brains.
Oh, wow.
So,
interesting.
Yes. Yeah. So, and my mother ate them regularly during pregnancy, which I'm forever grateful to her for doing that.
That's why you're so clever.
No, but they were always there in the freezer. And even if I go, there's some really special restaurants, obviously, that do whole animal eating, and I still absolutely love them.
Yeah, so both of us, I think, in our books have been sort of gently promoting the idea that humans do require some animal products. I know I'm kind of diving in straight away to one of the more controversial topics that's out there. Yeah. But I love in your writing how you call it a species-specific way of eating, because as humans, as Homo sapiens, we did evolve to eat at least some animal products. It doesn't have to be all meat all the time, but there has to be some there. And the beautiful thing about the organ meats that our ancestors used to eat is it's so nutrient dense. Yeah.
Yeah.
A good source of iron, also vitamin A, which you talk about in your book, preformed vitamin A, which is impossible to get from plant foods. Also, I'll just give a plug for a couple of other nutrients that are in organ meats. Choline is a big one.
Yes.
Which I think you've written about, and also inositol, which is very important for metabolic health. Those all used to be for our even recent ancestors, and by ancestors I mean even just our parents, or depending on how old we are, grandparents. They were pretty effortlessly obtaining a lot of those key nutrients. And the other thing that's contributing to the modern iron deficiency is heavy periods. And I'm sure we're going to get into that because that's kind of my area of expertise, women's health. And I do think maybe for a combination of reasons, periods are getting heavier for people. I mean, certainly it's a common experience for both women on the young end of this sort of teenagers and also, of course, perimenopause and the crazy heavy periods of women's 40s.
Yes. Thank you so much for saying all of that. And I guess too, when we talk about including animal foods, we are also humans. And so there is an emotional side to us. And we also get the option of course, of free choice, of free will. And so if we choose to not eat animal foods for whatever reason, or we choose for them to be a very small proportion of what we are consuming, I just think it's so crucial that there's education available that you may miss out on things like choline, of course, iron, preformed vitamin A. So there are some nutrients that are so crucial for you to consider. And what worries me hugely is that it might arise for someone because for all sorts of reasons that we don't need to unpack in this session, but it might arise for someone that that's the direction they want to go in with the way that they eat, and they don't necessarily know what they're then missing out on, and so it's not addressed.
Absolutely. And supplementation is one way to be able to sustain that way of eating. I will share, I mean, again, very gently, and I feel like hopefully in a compassionate way, because I know both of us work one-on-one with people. So certainly I've been in the room with patients who feel very strongly about not eating animal products for different reasons. And so, I definitely don't want to force people or make them feel bad or anyway, but I do have to say hand on heart that something I've actually said to patients in those conversations is, okay, we're going to try to work with that. We're going to use some supplementation, but also for an exclusively plant-based diet with no animal, like not even eggs or anything, then I will say to people, look, I think realistically we're going to have to lower our expectations about how healthy you can be. And it's a tough moment. And I sometimes would even tear up saying that to people. But
I get goosebumps when you say it with how difficult that is as a practitioner with a deep, caring heart, sitting with someone to open them to that potential reality. Yeah, it's a big moment, isn't it? And I think as we offer that to someone, it's I've certainly sat in the room with women where you can genuinely feel that it's their truth, that not eating animal foods might be part of their religion, or it might be just something that's evolved for them and it's their truth. And then I've also met lots and lots of people who do it as a mask of trying to control their weight or their body shape and size, and they think that cutting out those foods helps. It's almost like I've had women say to me, it's like eating flesh means we gain flesh, and we've moved on. We've moved on from that, I think, because protein
that is not true.
That is not true at all. No. But that was certainly around more so in the 90s and early 2000s. Women were still feeling that way, and so when it was coming from what I would call dieting mentality, then I also feel that as practitioners, gently prompting a reconsideration of that is really important.
And I also loved in your iron book how I think you explored a little bit about how is it your, like saying to people, to the reader, is it your truth?
Yes.
Or is it what you feel like other people expect you to do? Because there would be a lot of peer pressure. There has been. We're kind of coming out of it now, but for a while there was a lot of peer pressure to avoid all animal foods. And I think you're right. I think certainly from my conversations with women, sometimes their heart wasn't in it, but they really felt like that's what they had to do. And I mean, it's multi-layered. There's lots of different reasons. A lot of it can come out of fear of different things. And there's a sort of a squeamishness about it. I get that. Yeah. I will share it. I know we've sort of veered into this part of the story, but when I was a young naturopathic doctor and training, and I mean, I'd been raised on animal foods. So, but there certainly even at that time, there was, this would be in the 90s, there was some discussion of, ethical concerns around meat, which I get. And I felt that I think young females maybe feel that more, this sort of empathy with all creatures. And so I was still in my 20s, and I felt like on the one hand, even at that age, in that early in my career, I understood that medically, nutritionally, really animal foods are better, superior. They're more nutrient dense. But I felt I had to find a way to be able to do it. So in my case, what I decided to do was I asked one of my old, friend of a high school friend, because I grew up in rural Canada. So there were lots of ranchers and and hunters. And I know this one guy, I didn't even know him that well. And I knew he hunted meat for his family. And I said, can you take me out with you? I need to be present when this happens. I need to be there and witness it. And I had said to myself, I will not, from a spiritual perspective, I will not, if I can't witness this, then I will not continue to eat meat. This was sort of, and I'm not suggesting everyone has to do that by any means, but this was sort of an initiation for me. And so, I was there. It was very sad, of course. Then, of course, I cried. And what surprised me is this seasoned hunter, he was still a young man, but still he cried a little. So it was, it's real. I mean, it's a sacrifice by the animal. It's not nothing.
Yeah, that's right. And to acknowledge that, I think, is, really a beautiful and important aspect of all of this. Thank you. So even just talking about, I guess, a tendency to restrict food, it's something I imagine you've seen a lot of. It's certainly something I've seen a lot of with women of all ages, but it can begin in those teenage years.
Yes.
And certainly I see lots of young women who, just as their periods are starting, when their body actually requires more iron, it can be a time where they're very easily influenced by others, and of course their friends, but also they're people they've not even met on social media, and they might be drawn to trying a plant-based way of eating. And so I guess can we have a chat about teenage girls, because it's something that I'm particularly concerned about the direction it's going in, given that one of the symptoms of iron deficiency is actually anxiety. And I worry very much if it's not tested for, that they go down a purely psychological road. So can you share your thoughts around that road?
And this really came through in your book as well, that shout from the rooftops. This is a public service message. It's not a small problem. I quickly did I think this is in your book, but I also just, to refresh my memory, check the stats on my way here this morning. Conservatively, 40% of teenage girls are clinically deficient in iron. And that's not even subclinical deficiency, which, as you talk about in your book, ferritin should be above 50. So, I mean, that's an astronomical, that's a really crazy number. And one thing that just came into my mind as you were talking about, how this gets started. I mean, might get started, as you say, from different influences and deciding to restrict for different reasons, but it does become self-reinforcing. And I'm curious to hear your thoughts on this, if you agree, because one of the other nutrients, and you do mention it, is zinc. So animal foods are also a good source of zinc. And one of the things that zinc can help is to maintain a healthy appetite. So we know this actually from some of the eating disorder literature, that even just supplementing zinc can improve people's appetite in general, and for animal foods in particular, because actually we need good zinc levels to make enough stomach acid to even have that appetite for protein. Does that fit with your understanding of
Lara,
it?
completely. Yeah. So I looked at it. Zinc is responsible for the taste and the texture of food as well. So when someone, and you see this in younger children a lot these days, and it's almost considered normal. I like to say it's common, but it's not normal, where they're so fussy and so picky they might eat only 4 or 5 different foods.
Noodles and
and all the white brown foods, highly refined foods.
Yeah.
They don't want meat. I've had lots of parents say to me, with almost a smile on their face, it's as if my child is a vegetarian, even though we're a meat-eating family and the child's been offered meat a lot. They won't eat it. And my first thought there is they're iron and zinc deficient.
Yes.
And then it's that self-fulfilling prophecy. As you say, it's a vicious cycle, because they're not eating the foods to replenish what they're missing. And so they remain in this very self-restricted way of eating. So, zinc I see as key to that as well. And some of the children will even, I've had children say to me in practice, it feels funny in my mouth. Yeah. So, for me, that's very much a zinc scenario. And of course, then if they are not interested in meat, but the family eats meat, I would usually supplement them with iron and zinc.
Yes.
And then usually within a month, their diet had just naturally expanded on their own, and mealtimes were way less of a battle. So
so that's true for kids. I don't work with kids as much as you do, so that's really interesting to hear that side of it. Certainly I hear the same from older women, I'll get women in their 40s telling me, well, I just don't like meat. I have no appetite for meat. I'm like, well, that's a symptom. That's usually a symptom of zinc deficiency, low stomach acid, or both. Yeah. And you talk about the importance of stomach acid in the book. And there's lots of different reasons, including H. pylori or just high adrenaline. As you talk about, your rushing woman syndrome can lead to low stomach acid. Is that correct? Yeah.
Yes.
And that can, so in that sense, you can almost, the way I would interpret it is a low appetite for meat, or sometimes even an aversion for it, is a symptom.
Yep.
Yeah.
I wholeheartedly agree.
Yeah. And I say to people, that's going to just, as you just described for the kids, that will naturally come back online. As you get healthier,
yes,
you'll be naturally hungrier.
Yes. And do you find supplementation is required to get them there, or just force feeding yourself?
Yeah, I would never. No. So I think we agree that the force feeding never works for anything.
Yeah.
So yes, it would be gently. Usually, I would come in with a zinc supplement. I would try to correct the stomach. So sometimes I would, for example, depending on the individual, I might use a digestive enzyme, or sometimes even an HCl. Enzyme. This would be more for adults now. I wouldn't give that to kids, and also address whether they're on a PPI. So this is you talk about the medications. So a lot of people are fairly casually put on the stomach acid suppressing medications.
It is rife, isn't it? It is. And I sometimes will say to people, why were you put on this? Why are you taking it?
3 years ago.
Yes. Yes. And they're still on, and for everyone listening, they're medications that reduce stomach acid production, and you end up being deficient in all sorts of nutrients as a result.
Well, they're having, we could do a whole podcast on those medications, which we won't, but I'll just give a little, it's not only just do those medications reduce iron absorption, they reduce protein absorption. They also have a sort of rather odd array of sort of side effects and long-term risks, like including osteoporosis, weight gain, even dementia. It's quite strange, actually. And it's because it's not just about nutrient absorption. Actually, that switching off the stomach acid seems to have, obviously you probably know more than I do, it affects pH in the body. It does something. It's changing the immune system. And so it's, and I know once you've been prescribed something by your doctor, it's hard to question that. But a lot of the time, with that category of medications, I'll be like, let's just, in communication with the prescribing doctor, but let's just really back to the drawing board. Like, why was this prescribed? Is there something that could be used? An alternative.
Yes.
And sometimes there's not. Some people listening might have something called Barrett's esophagus or something quite serious going on. And so that's fine. That's one situation. But a lot of people just really had a bit of reflux, and there are other solutions for that.
Yes.
Yeah.
It's a bit it's heartbreaking when you meet someone and they've remained on a medication like that, when it's not something sort of more serious driving it. And it was just repeated reflux, but no one ever asked them to consider the pastries they were consuming or those sorts of really highly refined foods. Because when I think about reflux, I think it's almost the body saying, I don't want this right now. So it brings it back up, trying to get rid of it. And if we don't think like that, if we don't think, oh, what did I just eat that's just brought that on? We think, oh, we need to suppress the acid. When so often I think dietary change is something that is never considered in someone's picture, and it can make such a difference.
I can't count how many times I'm sure you may have done the same, that I've drawn when I'm sitting there with a patient, because I see people face to face, because it's so much better.
Yes.
And I will draw a picture of the stomach and the little valve on top, and I'll be like, okay, so the reality is the stomach is supposed to be very acidic.
Yes.
It's like battery acid, actually.
Yes.
Is that right?
Yes.
Close. It's a very low pH.
Yes.
And so that's normal. But what's supposed to happen is you have this mucus lining that's protecting the stomach, and then you have the valve on top that's shutting it all in so it doesn't go up into the esophagus. And there are lots of different reasons why that whole system might not be working. And a common one is small intestinal bacterial overgrowth, or SIBO. You must have had, you probably have content around that. We could put that in the show notes. Yes, pushing back up essentially. And also food sensitivities can cause that valve to just open. And so there's gluten's a common one, actually. I'll give a plug for gluten sensitivity.
Which is why I said pastry.
Yeah, I know. So people gluten, not everyone has problems with gluten. No. I eat gluten. But for those individuals, it's about 1 in 5, maybe 1 in 10 people really can't, even if they don't have celiac disease. They're just, gluten is not their friend. And one of the signs of that, or side effects of gluten in their case, can be that opening of the stomach valve. And it can be like night and day for those people. Like if they can make the right diet change, the reflux just improves. And then, but one thing to finally say about the PPI medications, they need to be tapered down, because once you're on them, you're kind of trapped on them, right? Because once the stomach acid is switched off, all those other parts of the stomach that I just described, the mucus lining, the valve on top, isn't functioning anymore. So you have to kind of slowly, over a couple of months, would you say, like sort of taper down the medication? Does that fit with what you might do with
Very much, over 3 months. And of course, as you said, in consultation with the prescribing GP, absolutely. Because when we think about the pH gradient of the digestive system, so beautifully acidic in the stomach itself, and then with that lovely squirt of bicarb that the pancreas offers into that first part of the small intestine, obviously elevates that pH. And then all of the enzymes required for digestion and for nutrient extraction from food, all of those rely on a pH range within which they can perform. And so the PPIs, I think, don't just obviously disrupt what's happening inside the stomach, but they mess up that whole pH gradient that the entire digestive system relies on. Now, that's not to say everyone get off them, because as you said, there'll be some people who literally require them. Otherwise, their esophagus will ulcerate, and we don't want that. But there are a lot of people, I think, who with some dietary adjustments wouldn't require them, those medications, and then you get the beautiful gift of a really healthy pH gradient through the whole digestive system, which I don't think is talked about enough. We spend a lot of time talking these days about the gut microbiome, and I'm not taking away from the importance of that at all, but pH as almost like an environmental factor, in the same way us as humans, we have a requirement obviously for certain environmental conditions so that we can literally survive in this environment. The bacteria inside of us also have requirements, and a pH range is one of them. And I love to think about that. What do they need to survive for the good guys to survive? I really
like your phrasing. I could tell you're a writer. The gift of the pH gradient. It's like that is, I mean, it does exactly, I agree. It sets up everything that comes later. There's no point in really thinking about lower down in your bowel if you've got a problem right at the top. Because one of the other things that the stomach acid does is it kills off some of the bad bugs.
Sterilizes.
Yes. So it does protect your microbiome lower down and influences it. Obviously, we're veering into the stomach and microbiome, but it's important for many aspects of health, including iron.
So a study, I talk about this in Fix Iron first, but a study was published in 2023, and it was called Psychiatric Manifestations of Iron Deficiency Anemia. And the researchers explore how essentially there are a lot of people who have been diagnosed with all sorts of conditions like anxiety or depression, or even ahedonia, the inability to experience pleasure. And so many of those people also had, or perhaps only had, iron deficiency. In other words, when the iron deficiency was addressed and corrected, the mood-related symptoms either diminished or resolved. And obviously, I'm not suggesting that all depression and anxiety is caused by iron deficiency, not for a second, but imagine if someone did have iron deficiency and we address that, it might improve their quality of life by 60 or 80%. And so those mood symptoms go from, say, an 8 out of 10 to a 2 out of 10. That's a very different life and quality of life. And it concerns me enormously that there are so many people of all ages, but particularly teenage girls, going down that road without addressing iron deficiency. So can you speak a little bit to your experience with the more mood-related symptoms in people of all ages?
So let's talk about teenage girls, because they're just being hit by everything. It's a triple whammy for them. So, and one of the things I'll just say at the outset about women generally, I mean, very, very young women, teenagers in particular, is just this tendency to blame ourselves. It's like whatever the symptoms are, it's like, well, I'm broken. It's just something about me. Like, I particularly am broken. And then especially once you're given a diagnostic label, it's really hard to shake that off, and it becomes very self-reinforcing. I will just give a plug for another book, if that's okay.
Beautiful,
which
please.
You may or may have read. It's getting a lot of discussion this year. It's called The Age of Diagnosis by Suzanne O'Sullivan. And have you come across this?
I haven't, but it will go straight to the top of my reading list.
She just takes a very kind of zoomed out look at the growing number of diagnostic labels that are being applied to people, and partly psychiatric, but not only that.
Yes.
And just how oppressive those can be for people. And there's another phrase I learned from a psychology friend for any sort of diagnosis is, it's beautiful advice is to wear it lightly. You know, if you have accepted a diagnosis of some kind, it's like maybe use that for whatever signposts or guidance you can gain from that, but it doesn't become who you are. Because there's always a possibility, depending on the diagnosis, to actually release that.
Yes.
It's like that's gone. But back to what girls are facing. So yes, I mean, there's a nutrient deficiency on a very deep level. Iron and zinc, those are the big ones. But and a lot of this is stemming from, yes, exposure to the modern food environment. Like we talked about it even not that long ago.
Yes.
People were eating organ meats every week. And the diet was very different. So, and I would argue that the female body is more nutrient hungry than almost the male body. That's, I mean, part of my work as a clinician and former evolutionary biologist is to center female physiology as the standard normal version of human physiology. Males are the like quirky variant, but the female physiology is very, especially during the reproductive years, very hungry, like just requires a lot of nutrients, especially girls as they're first getting their periods. I mean, they need a lot, and they may be restricting, as we've already talked about. They may also end up with heavy periods, which we've talked about, especially, and a message to parents or clinicians who are trying to help girls with those heavy periods. They will outgrow them. So this is one thing, coming from my work, is it's pretty normal for periods to be heavy at the outset. And that's because as the ovaries are kicking in and the communication between the brain and the ovaries is getting going, the ovaries are happy to make estrogen. They make quite a lot of it. And it takes them a while to learn how to make progesterone. And progesterone is the hormone that lightens periods, and estrogen is the hormone in general that makes periods heavier. So yeah, you'll get like a 13-year-old bleeding through her pad at night, bleeding into the sheets. It's very distressing. So, and of course, I would never, obviously my work has all been about providing solutions for that.
Yes.
But also it's just good to know that she will outgrow that naturally. It's not like that's how she's always going to be. And the other thing that comes into play at that time, of course, and this could be a whole podcast in itself, but is hormonal birth control will come online often at this point. And this is what I mean by the triple whammy, like everything teenage girls are faced with, because the oral contraceptive pill, for example, will create its own negative mood side effects, potentially. That's true for implants and other types, not just the pill. Yeah. Even the hormonal IUD can be associated with negative mood effects. And also the contraceptive pill will impair nutrient absorption, especially zinc and iron, which we've just been talking about. And then, so on top of that, then you might have an antidepressant coming on board, and it's a lot. Yeah. And plus, as I said at the outset, through all of that swirl of all of those very real biochemical reasons why girls' brains are not at their optimal, throughout it all, girls are blaming themselves, perhaps been given a label that you're, broken in some way. Yeah. And this is about throwing girls and, their parents, some lifelines, some ways out of this. Yes. And supplementing zinc and iron is a very simple. I mean, I know this is why you wrote the fix iron first. It's like it is a very relatively simple fix that is not going to fix every single thing, but it can be a great first step to climb out of that.
Thank you. I wholeheartedly agree. We're so on the same page with all of that, Lara. Yeah. It's why I called the book what I called it, because let's fix iron first and then see what's left over, because there will possibly be things left over. But if we fix iron first, it will deal with quite a lot, I find. And it's certainly something that when I was still seeing patients, I saw it time and time again, where a girl had been put onto the pill, not because she was sexually active, but it was to manage heavy periods. I know. And then within 2 years, she was on an antidepressant because of the mood changes. And by the time she's 16, she's on 2 of the world's most powerful medications, but she believes she has a disease. I know. And it's just it's heartbreaking, because they're the women who would then walk through the doors of our practices when I was still seeing patients, and they'd be 30 and they'll say, I've met the love of my life and I've been trying to have a baby. I went off the pill 2 years ago and I haven't been able to conceive. And then they'll feel like assisted reproductive technologies are their only road to it, but the communication between the pituitary and the ovaries was never well established because they went on the pill so young. And so they live with all this disruption to their physiology and their biochemistry, but also their nutrition because of heavy periods, but also because of what the pill does to iron and zinc levels. And it's so hard to, and I guess it's part of what I'm trying to do with these conversations and with this body of work around iron that I've brought to life. I want women of all ages, but particularly teenage girls, to know this and to understand, I guess, the what can come from those choices, because I worry that we don't, as humans, we so often don't change our behaviour until we've suffered. Yeah. And so I've noticed when I speak to a room of teenage girls, they get so uncomfortable and twist around in their chairs when you talk to them about periods and play with their hair. But it's not until they potentially can't conceive when they want to that they're like, I'm really interested now. But when they're young, they just want the heavy bleeding to go away. They want to still be able to participate in sport. They don't. It's I think arming parents as well with this knowledge of ways to support them when the girls are so worried about the breakthrough bleeding through school uniforms, and teaching them about the crucial importance of iron and zinc at that time in their life.
Yeah. So by bringing up this topic, it opens a little bit of my Pandora's box. Now I want to sort of talk about the pill a little bit. I won't spend too much time on it.
Please.
Yeah, because, well, first of all, we'll just say at the outset, we don't want girls to suffer. So, I mean, that's obviously my work's about. There are other solutions, other ways to lighten flow. Like, yes, girls should not have to put up with that. The other one is skin breakouts, which is another common reason to go on hormonal birth control. But one of the ways I frame it, because I think for teenagers, it's hard to think about, off in the future, one day when you want to have a baby. It's like that's not really computing for them. But the thing to understand is that regular ovulation, natural menstrual cycles, is how women and girls make hormones. And we need those hormones for general health, especially girls who are really sporty. The research is that actually our ovarian hormones, estradiol and even progesterone to some extent, certainly testosterone that the ovaries make, is beneficial for sports performance. And there is some evidence that hormonal birth control will impair sports performance. So kind of for some girls, that's going to be straight there, a clincher.
Yep.
But also just to frame it that the induced bleeds on hormonal birth control are not menstrual cycles, because that's been part of it. I mean, this idea that we'll just give you this medication to regulate your menstrual cycle, but they're not. There's no reason to bleed monthly on hormonal birth control. It's coming from a sense of history. Of course, we all have the sense. It's like, well, we've always done this. Girls have always been put on the pill, but it's really only the last maybe 3 generations. It's the last 60 or 70 years, and I think if the pill was invented now, people would really question it. But of course, it was invented at the time before people really knew much about the menstrual cycle or its the benefits of those hormones for the female body. So, and because it's just sort of been there in the background, it's been normalized. And one way I sort of like to phrase it is, imagine if we suggested that for boys. It would be so bizarre. Like, imagine if we said to boys, look, we're going to give you this medication to switch off your testicular function. So you're not going to make testosterone anymore, but we're going to give you back these medications that are kind of like testosterone, but not really. And they're actually going to affect your mood and your muscle mass and all these things. But don't worry, because that's what all the boys are doing. And it's just...
It would never have happened.
It's outrageous. So, I mean, I think, and actually my sense is, because I've been talking about this for a long time, I'm curious if you're hearing the same, but like I get the sense that the modern young women, or a lot of them are like, the message is kind of getting through your ovarian function is good. It's not just to make a baby, it's how you make your hormones. And a lot of young women are kind of coming on board with the possibility of having natural menstrual cycles and addressing symptoms in other ways. Obviously, we'll just acknowledge also avoiding pregnancy in other ways, because there's probably parents watching this, scratching their heads going, well, what do we...
Yeah.
So, I mean, there are solutions. I'll just give a quick,
please.
I think a combination of condoms and easy access to emergency contraception which is it's really just the pill, but like a big dose of a progestin that they would be taking daily.
Yeah.
But if in the unlikely event of a broken condom, they might need it once, which is quite different. So I hope that, I mean, there's other options. There's IUDs and there's something else coming for men, which will be quite interesting. So yeah, we should, it's 2025. There's no reason we should have to completely switch off ovarian function to avoid pregnancy.
No. And I think too, your work is making such inroads to helping people understand the biological role that our ovarian hormones play, so beyond reproduction.
Yes.
So we know that progesterone is a beautiful anti-anxiety agent because of what it does with the GABA receptors, and your books explain that really beautifully. And so it's helping people to understand it's allowing yourself to ovulate every month is almost like an investment in today, but also the future.
Absolutely. And have you noticed how, because of course we're at the moment, there's a lot of enthusiasm around perimenopause.
Yes.
And how I find it quite jarring, actually. Obviously I'm very interested in perimenopause, but there's this narrative that estrogen and progesterone are super important for general health, but only after age 45. I'm like, why do suddenly 40-year-old women, 40-something-year-old women need hormones? Yeah. But meanwhile, younger women and teenagers can just routinely switch them off and be without them. So just to really illustrate the point, when a person is on a combined, like an oral contraceptive or one of the combined synthetic estrogen methods of birth control, if you were to do a blood test, a serum test for their own estradiol, estrogen, and progesterone, you would find menopausal levels. I mean, they're walking around with menopausal levels of the hormones we need that then women in their 40s are trying to take back.
That's right.
It's the whole thing. Don't you find that very jarring?
Absolutely. Absolutely. And it's not okay. And we want to bring all of that to life. So yeah. Another really wonderful area of your work that I've loved learning about is the role that estrogen plays in iron and iron metabolism and essentially iron retention. So do you mind sharing some insights around, again, another really miraculous aspect of our body?
So this is a very natural segue. We were just talking about the many benefits of ovarian hormones and the wisdom of the body. It knows what it's doing. So estrogen, during our reproductive years, our high estrogen years, it has the natural benefit of actually helping iron absorption. And it does it by reducing hepcidin, which in your book you talk about, what did you call it? Like the gatekeeper or like the bouncer.
The bouncer at the stadium.
The bouncer at the stadium, which is, so when there's a lot of hepcidin, it's like, nope, please don't bring in too much more iron, because iron is one of those nutrients, and you talk about this in your book, we don't have a really easy way to excrete it, which is actually a problem on the other end when they get into the situation of iron excess, which usually not going to be a problem for young women, which is who we're talking about today. But so in our reproductive years, estrogen is lowering hepcidin, saying bring in more iron. That would be true during pregnancy as well. And then into menopause, post-menopause, when we stop bleeding and stop losing iron every month, then hepcidin is allowed to rise, to increase. Yeah.
So it's again another, I love to sort of bring to life how miraculous the body is, because I think we look after what we care about, whether that's the environment or our own bodies. And the more we're in touch with how it has our back, it's not trying to betray us. It's got all of these extraordinary mechanisms inside that are that are beyond our conscious control. We're not instructing hepcidin to go low or high. That's all just happening with our best interests at heart. And so it does fascinate me that depending on what's happening with estrogen, it either allows more in or says, no, we have enough right now. And it makes such perfect sense. And for people listening who hepcidin might be a foreign word to you, it's actually a protein that the liver makes, and it is essentially the guard at the stadium door saying iron can come in or not. So when hepcidin is low, it allows more iron to be absorbed, and when hepcidin is high, it says no more can come in. So hepcidin will typically be low when we need more iron or when the body wants more iron. And it will rise though when there is enough iron, but also in states of inflammation and infection. So because obviously bugs they'll take iron for themselves, so the body will try to protect us from absorbing more iron when we are acutely unwell.
Can I ask you a question? Yeah, because this is a both ways. I actually came here today partly to learn some stuff from you. So because of course hepcidin rises after exercise.
Yes.
It's like hours later. It's like 3 to 4 hours. So why do you think it's going up after exercise? I was just trying to get my sort of head around why all that is. Yes.
I think it's just an acute inflammatory response. And it's very temporary. Yeah. So we know that it peaks about 3 to 4 hours after exercise, which is also why if you doing blood tests to look at iron studies, it's really important to do it before you exercise. Don't have a blood test for iron after exercise, because inflammation falsely elevates our ferritin, our iron storage assessment. So hepcidin is there, I think, just as a response to the inflammation.
That's really important when people are getting their iron tests done. So how long could you, because I think I've read somewhere, or maybe in your book, you shouldn't have your iron studies blood test done within 24 hours of intense exercise. Is that about right? Yeah.
Yes. So if someone is an athlete, or they train like, a lot of people don't associate with being an athlete, but they train like they are. Yeah, it's really important to have that break of 24 hours before you have a blood test and before you go back to training.
And it also affects when you're supplementing iron.
It does.
I loved how you talk about this in your book. So yes, especially if you're a very active athlete or just amateur athlete, you should have your iron, try to have it before exercise.
Yes. And also, and that's in the morning. So hepcidin will naturally also rise in the afternoon.
Yeah.
So we know iron uptake is much better in the morning.
Yeah.
But then it can get tricky because the polyphenols in things like tea and coffee can disrupt the absorption of iron. And sometimes some people's iron status simply improves because they eat iron-rich foods or take an iron supplement and move that hot drink, that tea or that coffee, away from when they're having those iron-rich foods.
Yeah.
So, but iron absorption is better in the morning.
Absolutely. And also some people are if they're on thyroid medication, they need to take their iron away from that. So they're taking their thyroid medication in the morning.
Yep.
And also, is it true that stomach acid is a bit lower in the morning? That would be my
Yes, it is. So we want the pH to be beautifully acidic because obviously for iron to be soluble, for iron to, if it's a supplement, when it's bound to a salt or a chelate, the stomach acid has to actually separate it. Also too, stomach acid is key for if we're taking in non-heme iron, then it's in the form of Fe3+. And the human body only absorbs Fe2+, and so stomach acid is key for the conversion of Fe3+ to 2+, so that it can actually be absorbed. So,
so all the different forms of iron, including the ferritin form, which you talk about in your book, which is fascinating. So those, is it true that? So now I've just switched. Now I'm being the interviewer here. So with the heme, the heme form, the heme iron, which is from animal foods.
Yes.
And the ferritin iron don't rely as much on stomach acid as the non-heme plant-based iron. Is that
exactly?
Okay.
Spot on. Yeah. So yes, as you will be beautifully aware, the heme iron has its own absorption mechanism, and it doesn't rely on what's called DMT1. So DMT1 is almost like a transporter, like a truck that sits at the surface of a gut cell, and that's how non-heme iron is absorbed. So the most of the iron we all eat is in non-heme iron form, because even in animal foods, about 40% of it is heme iron and 60% of it is non-heme iron, even in those forms. So the DMT1 movement, the removalist trucks, they get a lot of work. They're also responsible for absorbing other minerals. So other minerals will compete with space on the back of that truck to actually get inside gut cells.
Yeah.
But that mechanism, so that non-heme iron absorption, is very reliant on robust stomach acid production. So, and it's also why we say to eat those non-heme iron forms with an acid. So vitamin C, ascorbic acid, any kind of acid though, but vitamin C is an easy one to pair those non-heme iron forms with for better absorption, to pop it into the form that we can actually absorb. That's
good. I didn't realize that animal products have both, right? They have the heme and the non-heme.
Both. Okay. Yeah. Yep. And it's been fascinating actually since I released Fix Iron First, because the current recommendations from the regulatory bodies who sort of put all of the RDIs and RDA sort of values in place, the current recommendations based on research is that if you eat vegan or vegetarian, you need to multiply the RDI by 1.8.
I saw that in your book. Yeah.
And there's been some conjecture that that's an overestimate, because even with heme iron, there is non-heme iron. Sorry, even with animal foods, it's a combination of heme and non-heme iron. But I think probably what gets forgotten when we eat purely plant-based is that there are so many iron absorption inhibitors present that can bind.
The tannins.
Yes, exactly. The oxalates,
phytates.
The polyphenols, the phytates, exactly. So there's and they can have all sorts of other benefits for health, but iron absorption is not one of them.
That's a good way to phrase it.
So they bind up the iron and make it unavailable for us. And so we can think we're consuming all of this iron, but if it's bound, we just can't absorb it. So,
a quirky biochemistry thing, which I'm just fact checking this with you. Phytate obviously has phosphorus.
Yes.
And inositol as its core.
Yes.
Is that right? So it's actually one of the plant sources of the nutrient inositol, which I mentioned earlier.
Yeah.
But they're from animal foods. More traditionally, we would have had inositol phospholipids, I think, which are quite a different, more absorbable form of inositol. So trying to rely on plant foods for inositol is not great either because it's coming in the form of phytate.
Yes, exactly. So beautifully said.
I'm good. I'm glad I got that right.
Spot on. So let's chat, Lara, a bit about perimenopause. It is having its moment right now. It's a word that I think maybe not very long ago only health professionals knew, whereas now it's everywhere. And I'll just share my experience of that, sort of sitting back and watching that. There's drawbacks and benefits, I think, to what we're witnessing right now. And the benefits, of course, are that when women are suffering and when quality of life is diminished, and there's a lot of support and help available now. So there is this really wonderful, robust conversation happening that you're not alone. It could be the effect of changing hormones. Have you considered that? And there's all sorts of solutions that can then be offered. That's, I think, a big part of the benefit because it's not been talked about. There's not been that support there. So that's beautiful and very much needed. There are some downsides, though, in my experience. And firstly, one of my worries is that if you're because perimenopause is not an age, it's a stage. And so we don't actually know when the initial transition is beginning. I worry that anything women experience right now between about the ages of 38 and 55, anything new, it must be perimenopause. And when we say it's perimenopause, we're essentially attributing what we're experiencing to changing hormones. I worry that all sorts of other things related essentially to metabolic health can be being missed. So what if the person is iron deficient? What if they're insulin resistant? You talk about that a lot in your work. What if the person has insufficient bile production? What if there's an underperforming thyroid? So I worry that I think our perimenopause experience overlays our pre-existing health, and if we're just going to throw hormones at things, we can potentially miss what's there. So that's not to deny that hormones can be beautifully beneficial and supportive. This is not an either-or conversation. I just worry, though, that when we say it's changing hormones, doing everything, that we can miss some other things that are there. And the other, just quickly before I sort of open this to you, because this is so your world, I also worry about what this current conversation around perimenopause and how it's affecting younger women. So if I chat to 30-year-olds, they're now terrified of it, and they don't need to be. So because we only hear from women who are suffering and they're sharing their stories to inspire and help and support others, and that's beautiful. But when I've done interviews with women who have very mild or no suffering, I'll say, have you shared your story? And the answer is consistently no, because they either feel guilty that they're not suffering when their friends might be, or they'll say, well, I have no story to tell. What am I going to say? I'm in perimenopause and I'm okay. So we're not hearing the other side of it. We're not hearing from the women who are going through it in a very mild or not a problematic way. So tell me your experience and what you think.
I was so curious as you were leading into introducing the topic, I'm like, what is Libby going to say? Because I agree with a lot of that. I mean, yes, obviously my perimenopause book came out 4 or 5 years ago.
Yes.
The whole conversation has dramatically changed. I didn't even put the word perimenopause in the title of the book because no one had really heard of it back then. And now, as you say, it's so it started with awareness raising, which is great.
Yes.
Sometimes I've lately been saying to friends, I feel like the perimenopause conversation has gone a little off the rails. And by off the rails, I mean it's gone over the edge of the cliff and is like a smoking wreck at the bottom. Like it's in this, and I say that only in that women are so fearful now.
Yes.
It's been pathologized and medicalized to the point that women are just like paralyzed with it's again back to what I was saying at the beginning of the interview. It's so common for women in particular, something is wrong with me. Something is deeply wrong with me.
Yes.
It's another label that we've taken on board. And you just gave the example of people who are maybe fine, not bothering to share their story. But I actually had a comment on social media. I knew things had gone too far, gone off the rails when I received this comment about just a few months ago. And she said, look, I'm clearly in perimenopause. I'm 48. My periods are by that point, becoming farther apart. She's like, but I feel fine. Does that mean something's wrong with me?
Lara.
Yes. And I thought, okay, this is gone too far. Yeah. Pull the reins. yes, let's back to the drawing board here, because it is a normal life phase. It's second puberty. Some women there's nothing about perimenopause that should be inherently symptomatic. Nothing. Like and arguably for our ancestors, it wasn't. I mean, certainly we know that because again, this is my background is evolutionary biology chiming in. Like we do know from the historical record, from cultures around the world, from the few people in the modern day who still have a traditional lifestyle, like the Hadza in Tanzania, they know about menopause. Like they know you stop having your periods, stop at 45, 50, you stop having babies. They're happy about it. Generally, they report no symptoms. I mean, that could be because they're not off volunteering the symptoms, but I think generally, I mean, they know their bodies. I mean, they're happy about it. Some of them use phrases like second spring, second girlhood. There is a vitality that can come online. So, and we're saying this partly to counteract the very negative narrative, and not to downplay that some women are experiencing strong symptoms. I get that. I mean, I still do see patients. I hear it firsthand. Yeah. And we can talk a little bit about what those symptoms are, but I couldn't agree with you more in terms of we're now in this kind of paradigm where literally like anything that's happening in your 40s, you just think automatically that must be perimenopause. And that's not always going to be the case at all. It is really about, I can sort of run through what some of the perimenopausal symptoms are. And before I get to that, I'll just say, because I've heard some awareness raising on social media saying, oh, we really need to make women in their 20s aware of perimenopause. I'm like, no, we don't. They need to be ovulating. Yes. They need to be what I was talking about earlier. Yes. Like regular ovulation is how you make hormones. They're in that mode. Yes. They don't really need to be thinking about perimenopause. And the other thing is, the encouraging thing, having healthy periods generally can lead to a healthier perimenopause because both periods and the perimenopause transition are an expression of general health. So in my first book, Period to Perimanual, I talk about the period being the monthly report card. In that analogy, perimenopause is kind of like the final exam.
But it's so beautifully said, Lara.
So that speaks to symptoms can be an expression of kind of what was underlying. Things that already perhaps needed addressing will be amplified by the fact that you're in quite a strong transition phase. And so those things will come to the surface. So yeah, but the encouraging thing is that a lot of the symptoms can be relieved. And also I will just say at this point, it doesn't mean people are doing anything wrong. No. It really doesn't, because in my metabolism book, I really tried to make this clear. It's not your fault. I mean, we're all of us living in a modern world, modern food supply, which is not nourishing, which is quite depleting in lots of ways. I mean, as you've talked about in your book, like the rushing women syndrome, like just, so all of those and environmental toxins and exposure to contraceptive medication and other medications, those are what are making it difficult to have symptomless periods and then a symptomless transition. But a lot of it is addressable.
And that's the message I want to bring to life for people, that I think our body it doesn't have a voice, but it gives us feedback about our choices. And it has our back. It's always offering us little prompts about, it's time to go to bed now. More rest is needed. It's time to go for a walk now. If you notice that you used to be able to pick up 6 bags of groceries, now you can only pick up 3. There's some feedback that your strength is diminishing. So we want to always be just not paranoid, but tuning into that information and that communication and making little adjustments, I think. And perimenopause is a beautiful time where, and you talk about this so beautifully in your work, that it's almost like progesterone offers us this glorious buffering for, I think, so much across the menstruation years. And then as we go into some anovulatory cycles in perimenopause, moving into plenty of anovulatory cycles, that beautiful buffering effect is lost. And so you might feel the consequences of what's actually there behind the scenes in a more intense kind of way.
Absolutely. Yeah, well said. So the nervous system has to recalibrate in the face of losing first progesterone and then eventually obviously losing a lot of estrogen. I'll just point out though for people, estrogen does not drop to 0. There's this idea that it's just, completely gone. That is not the case. It drops to about 10% of what our peak sort of ovarian estrogen would be. And that's significant. The body does have to learn to do things differently, and or, it's also okay to take some hormone therapy to help relieve that or mitigate that to some extent. But it's not a deficiency state. It's not a true deficiency state. It's not analogous at all to like thyroid hormone deficiency, for example, which is a disease state. And again, speaking through my background as an evolutionary biologist, there's a few beautiful papers about this. There's a few books about this. The evidence is we evolved to do this. Humans in particular, even compared to other mammals, have evolved to spend decades in the lower estrogen state. A close colleague of mine, my mentor, Professor Geraldine Pryor, some of your audience might know her. She's an endocrinology professor, scientist, still working in her mid-80s. She talks about being released or freed from the demands of the reproductive hormones, which I think is a really nice way to think about it, to reframe. Yeah, those decades of menopause or post-menopause can be really great. It's actually a time where testosterone shines through a bit more, which is the ovaries are still pumping out testosterone. Actually, that's what they shift gears. So testosterone will shine through. That's where you get the kind of assertiveness, the kind of bossiness of postmenopausal women, which we need in this world. I think that's partly why we evolved to do this, because women in their 50s, 60s, and 70s get stuff, and 80s in Geraldine's case, get stuff done. And we still do make, every cell in the body can make estradiol, our main estrogens. So the body can it's smart, as long as it's not sort of got too many other, as we alluded to earlier, like if there's other problems going on, then that whole recalibration process can be more difficult. And then that is where, and certainly we have to acknowledge in the research and the science, that the menopause transition can be a tipping point, tipping women towards, heart disease and dementia and other conditions. So it's something to pay attention to. I say to my patients, and I say in my book as well, if there was ever a time to, invest some energy and time into your health, now is it. Yes. Like your 40s it's because what you do now will pay dividends later.
Yes.
So on the topic of perimenopause, menopause, I might just give a quick little discussion of defining of terms, which I know sounds very boring, but
it's important.
Part of the confusion that's out there is the conflation of the term perimenopause and menopause and how it came about. So the word, I'm sure I'll just, we'll get down to basics just for just a few seconds here. Yeah. So perimenopause is the anywhere between sort of 4 to 10 years leading up to the 1 year after the final period. And then menopause, depending on who you ask, is either that kind of one moment in time, the 1 year after your final period, or it's the entire life phase that begins 1 year after your final period. So just for context, epidemiologists use the word menopause for postmenopause, for that entire 40-year life phase. But at the same time, some people, especially in the UK and here to some extent, use the phrase the menopause transition, or shortened to the menopause, is essentially synonymous with perimenopause. So you see where I'm going with this?
Absolutely.
So we get the word menopause being used for the perimenopausal years in some cases, that you go through menopause, kind of through perimenopause. And then some people, including many scientists, are using the word menopause for the whole postmenopause time. And the reason it's so important is that hormonally speaking, they're completely different. So the early years of perimenopause is actually a time of higher than normal estrogen and super heavy periods in some cases, like very heavy periods, which ties into our iron conversation. Whereas menopause or postmenopause, which word you want to use, is the time of no periods and not losing iron anymore. And in fact, there is, an argument to be made that and I'm in this phase now, that after periods are done and dusted, you can start creeping into sort of iron excess, especially if there's something like hemochromatosis but you don't, and this is what, and you're very clear about this in your book, and I'll just say it again, you should not take iron without testing, especially if you're in the years of no more periods. Yes. Because, sometimes with a young woman or a woman in perimenopause, if she's bleed at a certain point, I'm like, I know you need iron. Like if you're losing that much blood, menstrual fluid every month, then it's kind of a no-brainer. But other than that, you probably do want to test. And I'll just explain how much is normal to lose.
Please.
So anywhere up to 80 milliliters of menstrual fluid, which is about 5 tablespoons, I think if I'm doing the conversion right, over all the days of the period. So that's about the contents of about 1.5 eggs. If you can picture a half egg, which is beautiful, isn't it? Think of it in terms of that volume.
Yeah.
And some people might be scratching their heads thinking, oh dear, like I lose more than that. Yes, you do. Some women in perimenopause, so the normal is anywhere up to 80. And it's okay to lose like a little, like down as low as 10 mils too is normal. But so 10 to 80 would be normal. Some women, especially in their 40s, those crosshair, really difficult years of perimenopause might be losing like 400. So I'm sure you've had, clients like that. Yeah. And those are the women who are needing iron infusions. I mean, that is not sustainable. So it'll always be, in terms of treatment, it's always about increasing their iron, but also stopping the heavy periods.
That's right. Yeah. And I think too, getting to the heart of why someone is iron deficient, and that's a perfect example of that. So you don't want to just, I'm all about iron, of course, and restoring status, but you've got to correct the heavy periods and address the root cause. Or if it's a gut problem, address the absorption problem. So sometimes iron is a little signifier of other things that might be going on, whether it's heavy periods or undiagnosed celiac disease or some other gut condition. So it's a great
and
point.
Addressing heavy periods requires its own troubleshooting. It's always, everything in health is always about putting on the detective hat, isn't it?
Isn't it?
Like going a little deeper. Yep. It's like, why are the periods heavy? Yeah. And it could be, I mean, obviously that's the job now for the doctor or the gynecologist. Like, are there fibroids? Is there a very common condition called adenomyosis?
Yeah.
And I mean, there could be a coagulation disorder. For someone who's always had all their life had very heavy periods, I think the number is something like, 1 in 5 cases of very heavy bleeding is actually just a coagulation or blood clotting, like von Willebrand's or something like that. Yep. So that can be a little trickier. And then so the solutions would be, and also underactive thyroid or contributes to heavy periods. And as you say in your book, being low iron worsens underactive thyroid. Imagine the vicious cycle.
Exactly.
And actually being low iron makes periods heavier.
Yeah.
So women it's a downward spiral. If you get in that downward spiral of very heavy periods, underactive thyroid, that requires attention at multiple levels of support to bring you back up.
I agree. And also the lived experience of someone with that, so the incredibly heavy periods and then that underperforming thyroid, as well as so the role of iron in those things, but then also iron deficiency symptoms themselves.
Yes.
Life is more than uphill when that's happening. It's so difficult. And so, but I also think breaking the cycle with addressing the iron deficiency, addressing, as you say, on the multiple levels, addressing the heavy periods. The thyroid, I think I've seen it improve when iron status improves and the bleeding becomes less. So there is a solution, but you do need support on all those levels.
Yeah, maybe we should, I'm sure you've done this maybe in other interviews or other conversations, but we should just, again, for completeness, just list some of the symptoms of iron deficiency, because I just recently talked to a woman a few days ago who described it as having like nothing in the tank, like nothing there at all. Although you can maybe sometimes override it with pure adrenaline can sometimes override it, but it's this lack of spark. It's breathlessness, it's hair loss. I know during my menstruating years, now that I'm postmenopause and that is better, there'd be like, if there's hair all over the floor, if you're having to vacuum every couple days or every half a day, that could be iron.
Yeah. And the part gets wider. So, and I'm fascinated actually, it's often the little prompt that makes people actually act on it. They'll sort of put up with the breathlessness and they'll put up with the fatigue, or they think it's just part of a busy modern life. And then once the hair starts to thin, I find that that's often the motivating factor to actually finally address the iron deficiency.
It's true.
So, but it's really hard, I think, for people to sort of separate what is modern life, what is, the juggling act versus iron deficiency symptoms. There's also overlap with what we are currently attributing to perimenopause.
Yes.
There's overlap with an underperforming thyroid. And again, it's why testing is so important, because to find out if it's iron deficiency, your blood test will show that. And I have a phrase I use in my work, the road in is the road out. So whatever has created the problem, we want to understand that so that thing can actually be addressed. Yeah,
it's great that actually of all the nutrients, I think that the serum blood testing for iron is actually one of the most, there's just so many aspects. It looks at it from all different angles. And so you can really learn a lot from that, different patterns. But the other symptom is heart palpitations and brain fog.
Yes.
So we were just, even before we came on screen, or we were talking, there was a paper, we'll put it in the show notes, in 2025 that came in the journal, was published in the journal Menopause, and they tried to crunch some of the numbers, look at how many women suffering brain fog and other symptoms attributed to perimenopause, how many of that is actually just straight up due to iron deficiency from heavy periods. So, and then the beautiful thing about it is iron deficiency is relatively easy to fix. So as you say, fix it first, pull yourself out of the iron deficiency, and then in the case of perimenopause, look around, what else is left. And there could still be other things for sure, neurological symptoms that can also respond well to other nutritional strategies, sometimes hormones.
Yeah. The lifting of the brain fog is actually one of the things that brings me the most joy when people write to us and say, I've sorted my iron deficiency and my clarity of mind is brand new again.
Yeah.
But do you know the other thing, Lara, that I find when people say that they feel like there's nothing left in the tank when they're iron deficient, it's on a physical level, but it's also emotional. So I worry so much that women feel like they've lost their resilience or that it's diminished. And obviously, life can throw so many different things at us. And I worry that people don't believe in themselves anymore. Like they don't believe that they have the capacity to cope or handle with what's unfolding for them. And I know I'm making it sound too simple because obviously life is way more complex than this, but when we have robust iron status, our resilience, our emotional resilience is stronger. It's almost as if, this is still really painful or really difficult, but I can do this.
Yeah.
And it's a knowing or a trusting in yourself because there's a physical strength in you, but there's also this emotional strength. And I worry we don't want women to ever lose that or lose touch with that.
It is kind of a beautiful, in terms of metaphor, isn't it? Because iron is, of course, we think of iron, weapons.
Yes.
Or, iron's very solid.
Yes.
And it is what you're describing. Yeah, there's this sort of lack of this sense of lack of solidity. There's sort of nothing there when you don't have enough of this key nutrient for sparking so many things.
I had a girlfriend say to me she felt this sense of dread. She said it was if it just was sitting on her chest, this real sense of dread, and she was craving ice like there was no tomorrow. And I said, please get your iron tested.
Get your iron tested.
And not only did the ice craving go away, but that sense of dread completely diminished. And do you know what I think we do as humans when we feel – so they were her words, I feel this sense of dread. Your brain then goes looking for – what is that about?
Right.
So of course,
it's my work thing, or it's
it's my relationship, or it's whatever it is. So you label where you think the dread is coming from, and I'm not denying that all sorts of things aren't necessarily a source of that. But when we're not aware that our nutritional status and things going on with our biochemistry can also be contributing to the way we feel, we don't always look at it and we don't always address it. And I guess I just want to bring that message to life that nutrition is just such a powerful medicine. It's such a powerful recoverer of all sorts of things that we might think are due to other things.
Yeah, I love it. And also just for perimenopause, another just reminder to everyone, if they are feeling like you described, like a reduced capacity, I'm not going to be able to do the things I want to do, that's temporary.
Yes.
Whether it is just iron deficiency, which is fixable, or whether it's even more broadly, the hormonal, the recalibration with the loss of progesterone and then everything recalibrating, all of the research says it's temporary. And there was some beautiful, I included the citation early in my perimenopause book. It was some Australian research because Australians are so savvy with this. It was, I forget which university it was in Victoria. They found that most women in their 50s, later 50s, 60s, and 70s feel good. Any increased risk of anxiety, depression that occurred during perimenopause tends to resolve back to sort of normal or better. And they pulled a few quotes out of the surveys, and one was they said something like, most women, post-menopause or menopause report feeling, quote, pretty fantastic. So
that demonstrates how temporary the challenges might be. Yeah. Isn't that gorgeous?
So it's good for women to know this is not how it's always going to be. Yeah. They may very well be in a very difficult time where they're not sleeping, they're feeling anxious, but it's not going to always be like that.
Yeah, so reassuring. Lara, in 2011, I wrote a book, and you mentioned it earlier, Rushing Woman Syndrome, and when I wrote, that feels like 5 minutes ago, but that's 14 years ago. And I wrote it thinking that there was just this strange little glitch in the matrix where everything had sped up. And I really thought things would return to normal. And obviously I was very wrong about that. It's only sped up even more. And I think when I wrote that book when I was in my 30s, and so it was sort of for women who were busy at work, they were raising families, parents were moving into a more age situation where they might have been requiring care and support. Yeah. So I was trying to bring to life, I guess, the juggling act of modern women. But it was also at a time where our phones we'd moved already away from just landlines. We had mobile phones obviously for a while, but we didn't have the internet on the phones. And Rushing Woman Syndrome, I wrote that a couple of years after the internet kind of started to be carried around in our pockets, and then social media was not even on, it was only just coming online. It was all very brand new. And I think it's very easy to forget the way life used to be, and that the women who are now in perimenopause were the women, I was one of them. I wrote the book for myself as much as everybody else, but we were the women who, for the first time, we were contactable all the time, unless we chose not to be by turning our phone off or leaving it at home. And it's I don't think for younger people, they've not lived without that. Yeah. But the women now in perimenopause were the first generation of women to experience that. So, because you think we used to leave the house and no one could get hold of us until we either got back home or got to the office. Whereas now there's so many ways we can be contacted and always available. And if your nature is one of a people pleaser, which a lot of women have that as a character trait or something one of the ways they get approval, you feel like you're letting everybody down by not getting back to them promptly, because you worry people feel like they're not a priority for you, or you don't care about them, and it's part of our community and our kindness. And I'm not suggesting for a second that we should stop caring, because the world will fall apart if women stop caring. But I just want to bring to life that theme of sort of always being switched on, that constant relentless production of adrenaline. It's still fairly new to us from an evolutionary perspective. And I think the women who are currently in perimenopause were the women I wrote that book for originally. And so the impact of the nervous system and the impact of always living with that perception of pressure and urgency, I feel that's just as important to me as I guess that iron conversation to support women through their perimenopausal transition, and understanding that stress doesn't just pop us into that overdrive that can disrupt our sleep. Adrenaline obviously can disrupt our sleep, but obviously it impairs stomach acid production, so our nutrient absorption isn't as good. So it's this overarching disruptor, I guess, I think, to, the sex hormone regulation that our body is so capable of doing. And we talk about it a little bit, I think, when we talk about perimenopause, but there's no easy solution to it, because we all live in this modern world, but it's where our beliefs and our values, I think, are a part of what we're being asked to reconsider.
It is. I love how you phrase all that. It is about women giving themselves some permission to slow down. And especially during perimenopause. And as you have just described, that could be a time that's very busy. Career will often be peaking. You've got teenagers, those of us women who had children, you've got aging parents. There's a lot going on. Plus try to run an Instagram account, or, everyone's sort of like everyone's, it's a lot. And so sometimes I'll say to my patients, look, but unfortunately the biological reality, given the nature of the perimenopause transition, is it is a time, like I said earlier, about investing in your health, which does involve investing in some downtime, which is hard. And even I'll even sometimes phrase it, even from a financial perspective, like if people feel like I just have to keep working to pay the mortgage, and people have very real demands, but I sometimes frame it, could you slow down a bit now, if at all possible, like maybe let go of a couple of work tasks or commitments now, so that your health will hold during this tipping transition, or what the research refers to as it's sort of a tipping point for health during perimenopause. Come out the other side, and then if you want to, you're good to keep working for a couple more decades. You can sort of invest in your future energy and ability. It is hard to slow down. I'm guilty of that too. It's just so easy to get caught up in the just one more thing, attend to this. And
but I know you love hiking, and I imagine that's a bit of a circuit breaker for you, getting into nature and just using your physical strength to literally climb a mountain.
Yeah, to literally go up mountains. And the other thing that people, I think, another source of exhaustion is just becoming healthier itself. I don't know. I wasn't sure how to introduce this, but like, do you get the sense from people sometimes, certainly from my patients or on social media, I see it a lot, like this kind of never-ending quest for just optimizing health, becoming healthier and healthier. Like, what's the next thing? And so I do think we need sort of a circuit breaker on that. It's like, obviously we don't want symptoms. We don't want brain fog. I mean, that's why we're here today, to talk about ways to feel better. You don't want debilitating heavy periods. I mean, those things require treatment. But at the same time, we don't have to, I mean, at least through my lens, we don't have to optimize every single metric of health. It's health is for living and not the other way around.
Yes, Lara, I wholeheartedly agree.
Yeah.
And I worry too that a lot of people want health hacks, and no amount of cold plunging can fix iron deficiency.
No.
Like, we have to deal with sometimes we have to deal with basics first before we start optimizing, because the basics haven't necessarily been addressed. But then there are also people who have beautifully robust health and still feel like that's not enough. And we miss out on life.
Yeah. I'm like, maybe at some point, like, you're healthy enough. Just like go do the other things that, give you joy.
Lara, when I was still seeing patients, I would regularly see women who had low-end normal levels of iron and then an underperforming thyroid. So they didn't have a thyroid disease, but their thyroid hormone production was very much skewed to the underactive end. And it's where, again, that phrase I use in my work, the road in is the road out. I was always curious as to what was leading the thyroid into that hormonal situation. And obviously iron deficiency is one of them. The thyroid needs lots of nutrients to do its jobs. It needs iodine and selenium and zinc and iron. And then, of course, there are hormonal scenarios that can disrupt optimal thyroid hormone production as well. But when it came to just the TSH that was slowly climbing and T4 and T3 that was gradually dropping, my first suspicion was with iron deficiency when I would see that happening. And my worry, so many women are told we're just going to watch it and see, like, you've got some of the symptoms, but your blood work is still fine. It's still in the normal range. But because we don't do blood tests when people are at their optimal level of health, we do blood tests when people have some kind of symptom because we're trying to work out what's happening. We don't necessarily know what someone's optimal thyroid hormone picture looks like. So I guess iron is crucial for thyroid hormone production. Do you agree?
I couldn't agree more. Yeah, absolutely. And as you say, it's an easy fix. I mean, just do an iron studies and see if that is lining up with.
Yeah. And it's where moving in, to a conversation around blood tests, it's where testing can be just so helpful, because currently our normal range for ferritin, so iron storage in the body, which research shows correlates pretty well with bone marrow levels of iron. Obviously, we need lots of iron being delivered to the bone marrow to make all of the amazing new red blood cells. So the ferritin that we measure, the normal range for adult women in New Zealand and Australian pathology labs is 20 to 220 micrograms per litre. And I'll typically would see a TSH climbing towards the high end of normal, so normal range of that being 0.4 to 4, and I'd say the TSH will be at 3, so the pituitary is screaming out to the thyroid trying to get it to wake up and make its hormones. The normal range for T4 is 10 to 20, and the T4 might be sitting at, say, 11, so very low end of normal, and then T3 will be maybe sitting at 3.5 when we want to see it a bit higher than that, the active thyroid hormone being T3. And then ferritin would typically be in that very low end of the normal range, so it might be 22 or 25. And that is, I think, the beginning of so many health concerns for women, because nothing is optimal and they'll have all the symptoms of an underactive thyroid and iron deficiency all rolled into one, so they won't feel like themselves anymore. Their clothes will be getting tighter. They're often constipated. The brain fog has really kicked in. It's the fatigue is huge, and the diminishment in quality of life, I think, for women with that biochemical scenario going on is major. And I worry that so many women go into perimenopause and live through perimenopause with all of that. So it's never addressed.
I agree. I couldn't agree more. And isn't it interesting how, correct me if I'm wrong, but I think the ferritin reference range is different for male and female.
It is.
And I've heard some doctors saying, why? Like, why would women need, I mean, a lot of women are low, but that's not normal. I mean, it shouldn't be down at 20. When I read in your book that you see a cutoff of ferritin of 50, I agree. That's always the number I sort of used in clinic. If it's below 50, you need to address something, combination of giving iron or correcting the heavy bleeding or whatever is contributing to that. Absolutely.
Yes.
And the other thing with thyroid, and I definitely agree that I think a clinical or subclinical iron deficiency could be dragging down thyroid. Yes. The other thing, another useful blood test, which I think you talk about in your book, I'm sure you do, but is the thyroid antibodies or TPO antibodies, because there can also be this, even if with TSH just kind of in that gray area, like thyroid sort of in the gray area, but if there's the thyroid antibodies or TPO antibodies is the marker of autoimmune thyroid, or the antibodies the body's forming against the thyroid. And that, interestingly, in the research, that the level of those antibodies, if they're high positive, that correlates with symptoms. So brain fog, and it's quite interesting actually, even when technically the thyroid hormones are still in the normal range.
Yes.
And it correlates with increased risk of miscarriage and things like that. Yep. So, and there's a bit of a tie-in here in that, and I'm curious to see what other tie-ins you could make with iron, but it would be a lot of the same women. Remember how quite a while ago, 20 minutes ago, we talked about how a gluten sensitivity, even if it's not celiac, even it's non-celiac gluten sensitivity can cause reflux, can potentially cause low stomach acid, I would say, can impair iron absorption. I mean, that kind of gluten sensitivity can also play a role in autoimmunity and high thyroid antibodies. So that would kind of be the same individual who's got all of that going on. She might be on a PPI, have high antibodies. There'd be a family history of thyroid disease. Yeah. And so this is where I encourage my patients, certainly, I would usually test thyroid antibodies. In conventional testing, the antibodies aren't tested until TSH goes out of range.
That's right.
But you can just test it.
You can.
People can self-order it, or just get their nutritionist or their naturopath to order that. And it doesn't mean if the antibodies come back high, it doesn't automatically mean they need thyroid hormone. They might just need iron, or they might need to work on their gut or remove gluten or take selenium.
Yes.
Yeah.
I agree. Gluten-free way of eating is, I think when there are any antibodies, it would be one of the first steps I would do with people, and whether that's to address the autoimmune response and also, of course, to improve iron absorption. But for some people, that would be all they would need, if I'm honest. And when we feel like health is really complex because, someone might read an article about an underperforming thyroid, or they might read an article about stress or something going on with progesterone, and they think, oh, I'm all of it, I don't know where to start, then sometimes just some dietary change like trialing a gluten-free way of eating could actually, for some people, that gives them their quality of life back.
It does. It can be that simple. I'll give a little just cautionary mention about iodine while we're on the topic of thyroid.
Yes.
Because, of course, as you mentioned, it's one of the key nutrients that people think about for thyroid, but you do have to be very careful with it. Yeah. So, we need a certain amount of iodine, and sometimes, in full disclosure, in my clinical practice, I do use higher doses of iodine for some things, like for breast pain and even sort of heavy periods, and but that if there's a thyroid problem, particularly if there's a presence of thyroid antibodies or Hashimoto's, a higher dose iodine can actually worsen that quite a lot.
Yes.
So this is where, it's good to just think that through before taking a high dose.
Very much.
Iodine.
And I think it's best guided by a practitioner who is experienced in it and who knows your health history, isn't it? Mm-hmm. Yeah. Lara, another blood test that's really important when we're assessing for iron is transferrin, and transferrin will typically become elevated in iron deficiency and iron deficiency anemia, which can be confusing for people because they see as part of their iron studies, there's this thing that's high and you think, oh, have I got too much iron? But no, it's a good way to picture it for people is that it's a taxi that drives iron around. So your body is producing more taxis, trying to pick up more passengers. The passengers obviously is iron. Mm-hmm. So the normal range for adult women in New Zealand and Australian pathology labs for transferrin is 2 to 3.6 grams per litre. In my clinical experience, once transferrin goes above about 2.6, I see it as a sign of iron hunger. So that's the body seeking more iron. So again, we talk about normal ranges and we talk about optimal ranges. So I like transferrin to be between about 2 and 2.5. That's, to me, that's the body's satiated for iron right now for whatever reason. And so obviously blood tests can be complex and there can be all sorts of different combinations of, is it low ferritin with high transferrin? That's classic iron deficiency anemia. But you were sharing with me earlier about an experience you had with a patient who had low transferrin but very low ferritin as well. Do you mind sharing that?
Yeah, well, I have to thank you because it was only when I was reading your book cover to cover and sort of looking at all the details, and I was able to, because I fortunately, it was around the time I was trying to help a patient with this, and she just her ferritin just kept dropping, and there was not, and she'd had infusions. We haven't really talked about this, but she'd been trying to prop that up with infusions, but it wasn't working. And I had assumed heavy periods, but it really wasn't that in her case. So there was something else going on. And I realized, because even as a clinician of 30 years, I had still not quite got my head fully around the iron studies panel. It is complicated. As you said, it's sort of counterintuitive where transferrin sits compared to ferritin. And also the other confusing thing is ferritin can be artificially elevated by, as you mentioned, inflammation and other things, and that can mask an iron deficiency. So there's a lot going on with an iron studies, actually.
There is.
So I'm not ashamed to say that even I was like still struggling to figure this out. So I had a chance to ask you earlier, with this patient, what I managed to figure out, I think, so she had very low ferritin, but she had the unusual pattern of also low transferrin. And this was in the context of a mostly kind of plant-based diet. And we did calculate that she was eating probably only like about 30 grams of protein a day, which is actually not that unusual sometimes for even not even plant-based. I mean, some women are just not hitting probably should be closer to like 80 grams of protein. And so I thought, and a little bit of talk with ChatGPT and then talk with you earlier, I thought, could the low protein intake, in her case, explain the low transferrin?
And very much so.
Okay. Yeah, that's good to know. Yeah.
And even to think that when we think about protein, I think a lot of people immediately think of their muscles, the visible pretty ones.
Yeah.
When your body is forever making all these little proteins. Transferrin is a protein, ferritin is a protein. So the body makes lots of protein inside of it, and everything's prioritized, isn't it? So if there's not enough of something to go around, the things that are essential for life to be maintained are always prioritized. But also we actually need to have enough protein going in for our iron metabolism to be healthy. So iron is not just about iron, and we've talked about vitamin A, we need copper, there's all sorts of other cofactors, and protein is one of them. So it's, you see the whole big picture, don't you, when in a scenario like that. So, and it's important to note too that you said that your patient was really actually quite healthy. So she wasn't acutely unwell, because the body will drop transferrin when we don't want more iron because we might have an infection as well. So
right, so that could be a sign of a. I think I'll go back and sort of triple check that she doesn't have, because there could be like an underlying gut infection or something like that sometimes requires a bit of extra testing to detect. But you mentioned vitamin A. It was actually reading your book, I learned that actually one of the ways that correct me if I'm wrong, but one of the ways that vitamin A helps with iron metabolism is it helps retrieve the iron stores from the liver and bring it into the body. So a vitamin A deficiency can mean the iron just kind of gets locked away and the body can't. Is that right?
Spot on.
Yeah.
And so when we eat iron or take an iron supplement, it all ends up in the total iron pool, and then that total iron pool says, right, well, you're going to storage, you're going to the bone marrow, you're needed for thyroid hormone production, so it's all sort of dished out. But once we put iron into storage, obviously we store it inside ferritin. For it to be able to come out of storage, the vitamin A is crucial. And so if you think, here's the bone marrow saying, I'm making 1 million new red blood cells, 2.5 million new red blood cells every second.
That's crazy.
Isn't it? And so if the bone marrow is sort of saying, hey, I need more, and there's not enough actual vitamin A, then that can't happen efficiently. And so there can be a lag. So that's why the cofactor nutrients are just as important as iron itself.
You know, just back to preformed vitamin A. Like this kind of circles back to the beginning of the conversation. We were making, I hope, a gentle, compassionate case for some animal foods, products, because that's really the only way you can get preformed vitamin A.
It is.
My experience with when people try a vegan diet, and there's often a honeymoon period because they'll feel amazing coming off dairy or something.
That's what I think it is.
They just feel like, oh, my periods got lighter, my period pain went away. I just feel amazing. I think it's dairy. The people with dairy sensitivity. But then the honeymoon period will end, and it's kind of like there's like a 12 to 18 month time when their immune system will crash or something will happen. And my interpretation, I mean, I'm sure it's lots of things, but one thing is, I think it's their vitamin A stores. I think it's like that's how long it takes to deplete vitamin A stores. And the body can I think you talk about this in the book, but that we can convert beta carotene to vitamin A, but only a certain amount, and that's genetic.
Yeah.
So some people have that dialed in quite a bit more than others.
Yep.
So I think the people who are just not good at making their own vitamin A from beta carotene are the ones who are going to fall flat on a vegan diet faster.
Yep.
Does that track with your? Yeah.
Very much. Around the 18-month mark is when you don't feel that great anymore. As you say, it's usually in a big immune event that makes someone go, oh, I'm not so sure about this, or what now what am I missing? But they've had sort of that 18 months where they haven't necessarily been getting all of their nutrients, and you feel it after about 18 months. It's such a pattern. Even when I do speaking jobs, and there might be lots of people who are incredibly health conscious and they're in their 50s and 60s, so 70s, and so they've had a lot of experience. And if you're in the green room, someone will usually lead the conversation. I'll put your hand up if you were vegan for a while, and most of the room puts their hand up. And then usually that person will then say, when did you crash? Put your hand up if it was sort of between 18 months and 2 years. And again, most of the room puts their hand up. So I feel a lot of people try it and then their body gives them feedback it's not working for them. But that's not to say that there are people who are deeply committed to it and find a way to get their nutrients going in, but you have to know what you're doing, and you require supplements in my clinical experience to be able to do that. Yeah.
So let's talk about iron supplements.
Yeah.
Because I'm very curious. I had not known that you could supplement iron in the ferritin form. So tell us a bit more about it, because I'm pretty sold on the idea actually, because as you say, it's a whole different absorption pathway compared to the heme and the non-heme that we've been talking about.
Yeah, it is. So obviously the conventional iron supplements are either iron salts or chelates. And so when we swallow those, they are separated in the stomach acid. So the iron is freed from whatever it's bound to. And then that iron is delivered to the gut cells. It's delivered to that DMT1 truck that we talked about earlier that sits at the gut cell surface, and it takes the iron inside the cell. So it does expose the gut cell to free iron, which in high doses is inflammatory and can drive oxidative stress, which is what I think drives some of the symptoms associated with conventional iron supplements. Yeah. You also, to get iron is still in the cell, so it's not in the blood at that point. And to get iron out the back door of a gut cell, you need an enzyme that's completely dependent on copper. So if someone has not enough bioavailable copper, then that iron just sits inside the gut cell, and the worry is obviously it can be damaging to gut cells. So and also you end up with not enough getting into the blood.
Iron.
So the beauty of ferritin iron, I developed a supplement. It took a long time to do it, and I did a lot of different trials to get there. But the ferritin iron is sourced from organic peas, the humble pea. And just like humans, the peas store iron inside themselves, inside a ferritin protein cage in the form of ferrohydrite. So there can be up to 4,500 iron atoms inside that protein cage. And then when we swallow it, when we extract it from the peas and concentrate it into a supplemental form, when we swallow it, the majority of it escapes degradation by stomach acid. And so the ferritin cage containing all of that iron is delivered directly to the gut cell, and it absorbs it through its own unique absorption mechanism, which has a geeky name, receptor-mediated endocytosis. I know some people listening will be geeks like us, but people listening don't need to remember the silly name. But if you just imagine that the gut cell, the simple way to picture it, it's just engulfs that entire little unit, the ferritin with all the iron inside it. So now it's inside the gut cell, but the gut cell itself is not exposed to the free iron. Yep. And then you also don't need the copper. It getting out the back door is not dependent on copper, so it's delivered to the blood and then into the total iron pool. So we're getting really extraordinary results with its use. So people who have had consistently low ferritin have been chronically iron deficient, so ferritin below 20. People are writing to us saying my ferritin was 14, and in 3 months of 11 milligrams of ferritin iron per day, it's now 43. And this has changed, and so it really moves the needle. When I was seeing patients and this sort of supplementation wasn't available and I might have been using an iron chelate, I was excited if it moved the dial by 4 units. We knew we were moving in the right direction. So if someone is really low in iron, we've always felt like infusions are the only way to go, and I'm not taking away from that. Sometimes they are appropriate and can be life-saving. But with the very efficient, the highly bioavailable nature of the ferritin iron, it's very exciting to see the difference it can make in people's lives.
Yeah, I'm intrigued by the whole thing. Because I guess I also had been relying on the chelates, but I mean, this is another something else to try. And also I learned from you today before we came on air that some of the liver supplements do not actually contain as much iron as I had hoped. I think there's been a bit of wishful thinking around those. Maybe some of them are better than others. Is that?
Yes. And some of them are definitely better than others, but some of the big name brands that a lot of people are relying on for their iron. So if you don't know how to read a label properly, you could be sort of missing the trick with this. So in one of the big name brands, one serve is 4 capsules, but one serve gives 0.5 milligram of iron. So even to get 10 milligrams of iron going in, when women across the menstruation years need 18 milligrams, but even to get 10 milligrams going in, that's an exorbitant number of capsules. And no one's going to take 80 capsules a day. So you can be thinking you're doing the right thing and you're not necessarily getting it. Whereas if you ate 100 grams of actual beef liver,
yes,
you'll get 6 milligrams of iron and a lot of heme iron in that, which has its own absorption mechanism. So, and it's highly bioavailable. So yeah, the food versus those liver supplements, they can be worlds apart and people can be missing the trick. So
as we're talking, I'm thinking about some patients who I think are using, I'm going to have to go back and read the fine print on their liver supplements and figure out how much they're actually getting.
Lara, one of the things, there's so much I love about your work and appreciate about your work. One of them is the way you really help women to advocate for themselves. So if, you know, even in your book, you have these beautiful statements. If you're struggling, you know, to get the support you want from your medical practitioner, here are some ways you can sort of ask for more testing, for example. And it's something that we get feedback about regularly that, for example, with iron studies, the GP might only want to test ferritin, not do the whole picture. And you can miss a lot if you're only testing ferritin. And it might be that they have a more complicated health picture. So it might be that CRP needs to be tested for inflammation to see if that's messing, in this case, with iron. Or so are there ways that you sort of encourage women to have these conversations? I know sometimes it can feel uncomfortable and we feel like we need to be quite brave, but how do we help women advocate for themselves to get the testing that they're seeking?
Yeah, so those sections in my books are called How to Speak with Your Doctor.
Beautiful.
And I'll preface it by saying you can always, if people have reached sort of an impasse with a doctor where you feel like maybe you're speaking different languages to each other, you can just say, look, can I leave this with you and I'll come back next week? Because bear in mind, the doctors are busy and they do have a lot going on.
Absolutely.
And if they're peppered with too many questions in one session, they're not going to be able to. So sometimes it's just practical to say, I'll make a second appointment next week. I'll leave this information with you. And a lot of the questions in my How to Speak with Your Doctor, they're about trying to put things in doctor speak and often sort of phrasing it as a question. So in terms of our conversation today, some questions that come to mind, certainly, could be, do you think it's appropriate to have a full iron studies panel? Because my understanding is actually you can learn a lot from that. Could my very heavy periods be responsible for why my ferritin is low? You could even say things like, my understanding is that, a chronic inflammation or potentially an infection could be skewing these results. So do you think it's worth kind of testing for that? I talked about thyroid. You could definitely say I have autoimmune thyroid disease in my family. Do you think I could also get the thyroid antibodies test? In addition, I'm willing to pay privately for that because that's another, especially in Australia and New Zealand. It's a bit different in the States and different places, but you can always just opt to pay privately. Yeah. And you can actually self-order a lot of these tests. But self-ordering iron studies, I mean, you can do it, but you do need to sort of have someone help you interpret it sometimes because I'll just reiterate, you said it before, it can look a little counterintuitive, especially if transferrin's high, which it's often going to be. So you have to be able to sort of either take on, the details of that yourself or talk to a nutritionist or clinician.
I agree.
Yeah.
And I think too, we ask so much of our GPs these days and to also be open to going elsewhere. So it might be that you need the support of a nutritionist or a naturopath and you'd have to pay for blood tests if you do it through those people. But I feel we need to be open to all those different ways of getting blood test results.
But for context, the iron studies blood test is not expensive.
No, it's
Even
not.
if you pay for it private, it's like $40, isn't it? Something like that.
And so worth it.
It's money well spent.
It is. So, Lara, you have been so generous to sit with me and have this conversation. I am so grateful. I've just loved every minute of it. I could talk to you underwater for the next 65 hours is how it feels. So thank you. So just in closing, could you share maybe something that you're concerned about with women's health, and then also what you feel really hopeful about when it comes to women's health?
Yeah, those are great closing questions. Well, I guess, what comes to mind, this comes up a lot with anyone who works with women is, your body's not broken. There is an explanation. You may already have, a diagnosis, a label given to you. I would just repeat what I said earlier about wear the label lightly, wear the diagnosis lightly, because there might be something else going on. And yeah, I guess I'm hopeful. Like, I want to communicate that the body is smart and it knows what it wants you to be well. And I guess if I'm really honest, I am hopeful that the conversation is shifting around hormonal birth control. That was part of our conversation, a little while ago. But I am seeing more and more young women just, digging in. Like, they're like, yeah, I don't want to put that in my body. And I, from a sort of more broader, zoomed out culture and history perspective, I actually feel like young women, teenagers including, are quite influential in our culture in just kind of a quietly tectonic way. Like they move the needle on something, don't you think?
Yes. I've had so many goosebump moments sitting here with you, and that's another one.
And so, yes, hopefully some of them are listening today. You're amazing. Like by you, well, you are amazing also, but by you, young women are amazing. They've always been a force of change in society. And so to fully embody that, they want to be fully nourished in every respect. Do not be afraid of food. And being fully nourished for sure includes iron.
It sure does. And please know that the difference you're making with your work, and you have shone a light on that conversation for such a long time, and your depth of caring just beams out of your eyes when you sit across from you. So not only are you this extraordinary font of knowledge, but your care is deeply felt. I can feel it sitting here. So it's been my absolute privilege to have this conversation with you. Thank you so much for spending this time with me and sharing all of your incredible wisdom. And I hope to everyone listening that it's been so beneficial. And if things bubble to the surface, I encourage people to act on them, because it's taking new actions that enhances the quality of our life. So thank you, Lara, so much.
Oh, thank you, Dr. Libby.